I didn't belong. They saw something that was out of the ordinary and stopped me to question me. What are you doing here? What are you doing here? And it was difficult to explain my what I was doing there, and they did take my word for it. However, it could have just as easily been, an excuse or a lie that I was telling them.
So your bottom line is what, Joe?
Is that as far as if in fact this was racial profiling, I'm assuming Professor Gates has a nice house in a nice neighborhood and everything, but you can't blame. It's a human condition that when you see, and especially with all of the training that these guys get as far as not doing the racial profiling, it's still it's a nice house and a black guy crawling through the window or whatever he was doing. I'm not real familiar with exactly what happened, but that's the idea that I get. It was similar to when I was crawling through my window at my house.
Okay, thank you, Joe, very much. Next call is from Austin, and this is Ardell, Republican line. You're on the air, Ardell.
Yes, how you doing? It's sad, a country that could make me so proud to elect Barack Obama as president hasn't really changed. I live in Austin, Texas, and when I ride around with my Caucasian friends to go see my mother who lives on the east side of town, we're pulled over. Can't be a black person and a white person riding in a car together unless they're up to no good or they're going to do drugs. And then it's not an apology given if you don't have drugs or they search your car and they don't find anything. It's aftermath fact, like you shouldn't have been here. How can things be so changed and still be the same? It's sad. What they did to this professor was insulting. People calling in keep forgetting that the man showed them his ID, and the police officer still refuses to apologize. If you do something wrong, it's wrong. It doesn't matter whether you're black, white, or otherwise. It's like I say, it's just so sad that we could have changed so much, but yet still remain the same. Thank you.
Thanks. Ardell in Austin, Texas. From the Boston Globe, which I mentioned has many sidebar stories about this, the photograph that we've seen of the arrest, there it is right now, was taken by a neighbor. Here's the story behind it. William Carter was headed out from his home on Ware Street in Cambridge for his daily coffee and crossword puzzle at Oban Pan in Harvard Square on Thursday when he saw a commotion 4 doors down. Carter, a 58-year-old former manager at Bank of America, saw 4 police officers on the porch and at least 6 or 7 police officers in the street. So I grabbed my camera because when you see police, you know something is going on. Something was. Moments later, Carter snapped the only known photograph of a handcuffed Henry Louis Gates Jr. Carter said Gates was agitated as police let him off to face a charge of disorderly conduct. I had no idea who he was. I just took one picture of him and was on his way. Interestingly, he went to an agent with that, and he has now earned over $4,000, which will be split between the photographer and the agent. We had a caller from Illinois, and Chicago Sun-Times has put this story above the masthead this morning. Obama police acted stupidly. And inside, they have another story. Mary Mitchell says arrested black professor should have known better. So 2 sides of the debate. Next is a call from Washington, D.C. George, Democrats line. Good morning, George.
Hi. I was raised to believe that the police were there for us and to respect them and so on. But, I'm 47 years old now, and every time I've had an encounter with the police, never because I did anything wrong, they act like jerks, and I don't understand what that mentality is. And I'm a white person, and so I probably don't experience it as much as minorities do. But, there's got to be some kind of training that can be done for police officers to maybe allow them to not have that attitude of confrontation. They're supposed to protect and serve, I think, is the second part of the slogan. And, I feel bad for Professor Gates. I don't agree with Professor Gates on most of what he says, but as soon as I heard about this, immediately could picture myself in that same situation. And, you know, we have to work together with the police, and they have to work together with us, and that's not been my experience, and I'm very sad about that. It's a shame. Thank you.
George in Washington, D.C. Teresa from Twitter says, I agree with President Obama. This was racially based stupidity on the part of police. Our country is loaded with officers like him. Be interesting if there are any police.
You can see the remainder of this discussion on our website at cspan.org. We'll leave it now to return to a discussion on health care legislation hosted by House Republicans.
Which is responsible for creating the largest independent cancer network in the UK. His picture's there on the screen in the back, and he's on the phone with us. Among his many accomplishments, he's been a physician in the National Health Service in the UK for the past 37 years. He's the author of over 300 papers and numerous books. And Dr. Sikora, we're glad you're with us and look forward to your testimony.
A pleasure. Well, thank you very much. I think I've circulated a little preamble about the NHS. I mean, the problem is not unique to any country. All developed countries are struggling with new technology, aging populations, and an informed public that are behaving like consumers on health care. Medical inflation is now running at about 10% per year, so in all economies. So inevitably, financial meltdown is going to happen. Now, in Britain, we've had a National Health Service for 60 years. It's its 60th birthday last year, great celebration. And it's creaking, there's no doubt about it. We're sort of in love with it. It's sort of a religion in Britain. And the words that when the NHS was created, free at the point of care, based on medical need, not ability to pay, has become a sort of catechism. And the great thing about the NHS, which is wonderful, is its universality, that no one is uninsured in Britain. And that is just a tremendous attribute. The difficulty is that politicians play with the health service for political gain. It's inevitable if you have a government-run health service that's essentially run by the politicians ultimately, they're going to look at ways they can score votes. And this happens locally in small areas where service planning to change hospital configuration is out to consultation. The politicians make political statements to encourage people to vote for them. And similarly nationally in terms of policy. So if you take my area, which is cancer medicine, certain cancers become more important because they're politically more important. And, you know, breast cancer is more important than colon cancer for a variety of reasons. So if you're a rational provider of a service, if you say a supermarket or a mobile phone company or a budget airline, you want to please your customers. In healthcare, especially government-run services, it's very difficult to do that. And there are really 5 problems in government-run health services. First of all, you get a huge bureaucratic workforce. We're the British NHS is the larger employer, single employer in the whole of Europe. The second problem, and when you've got a large workforce that's bureaucratically structured, there's tremendous resistance to change. If you look at any other consumer area like the high street, shopping malls, it's changed dramatically in both our countries over the last 30 years. Our healthcare system really remains almost exactly as it was 30 years ago in many ways. The second problem is what I call the value equation. Choice and competition, which you've heard about earlier this evening or this morning, choice and competition drives value. And I would define value in healthcare as the quality of the care, together with access to that care. Our patient from Canada had to wait several months if she stayed in the Canadian system. That's poor access, divided by cost. So if the quality goes up and the access goes up and the costs go down, the value goes up. And that's the driver in any consumer industry, service industry. Operations set up, they compete, and those that provide better value, as judged by the end user, win out. Those that provide poor value close down. And that dynamic occurs everywhere, except in a government-run health service where it can't. The third problem I've already mentioned, political buffeting. It's inevitable. We've seen it both with our Conservatives and with our Labour. There's a lot of buffeting going on with the health service. And, you know, it is one of the most important issues to people, how their health care is going to be provided. And I think politicians struggle to find ways to solve the crisis. And one way of struggling is to pretend it's all going to go away. And of course, the issues, as we've heard from you, the consumption of GDP potential is just massive. Then the fourth problem is a rather delicate one, and that's that the majority of healthcare goes to our senior citizens, to older people. And I'm nearly there, so I'm going to be one of them very soon. And, of course, older people tend to pay little tax. So in a tax-only based system such as ours, the NHS, you're asking the older people who now have all this wonderful technology at their disposal to get it at a cost to the younger people who are going to have to pay more tax. So you put more and more tax on younger employed people to pay for the healthcare wishes of aging health consumers. And inevitably, you get to a tipping point where it's just no longer possible to tax younger people more. And that is a huge political problem. And then the last problem with a government-run service is you've got to ration it. It's the only way to do it. We sort of do it here through an organization I'm sure you've heard a lot about called NICE, the National Institute of Clinical Excellence. And the problem with NICE is its value judgments are not agreed by everybody. You can't reduce healthcare to single numerical comparative values. So we use the cost per quality, the cost per quality adjusted life year. And if you try and calculate that, and there are all sorts of arguments for health economists about the calculations. But again, in my area, cancer, which is going through a rapid upsurge of new technology, mainly new drugs, how do you really know whether giving a new drug for cancer is a better health intervention than doing something, say, for mentally handicapped children? And that's impossible to put into single numbers. And so trying to get, in conclusion, some sort of system that allows the benefits of universality, which the NHS certainly does, but allows choice and competition to move through, is clearly, to me, the way we go through. But what I do admire about what you're doing, both you and the Democrats, you seem to have a greater realism, a political honesty about it. We tend not to have that here, probably because of the NHS, but it's coming. It's coming in the next 3 to 5 years, I guess, because of the increased cost of healthcare and the fact that new technology is going to keep coming at us. Solving the problem today doesn't mean it's going to be solved for 2 years, because we still new technology that people know about. Thank you very much.
Well, thank you, Doctor. And if you can stay with us, we got 2 more witnesses, and then I'm sure we'll have some questions for you as well. Let's go next to Richard Baker. Richard founded Timely Medical Alternatives. It's an organization that sends thousands of Canadians to the United States for surgical procedures. He's become one of the leading spokespeople for free market reform in the Canadian single-payer healthcare system. He's appeared often on radio and television to discuss healthcare reform, and like Shona, made a considerable effort to be here with us today, and we're glad you did. So, Richard, thank you. It's working. Well, it was working.
How about now?
Yes, it's working now.
Mr. Chairman, ladies and gentlemen, my name is Richard Baker, and 6 years ago I founded an organization to help Canadians who are on long medical waiting lists to get timely care in U.S. hospitals. Now, currently there are over 750,000 Canadians who are waiting for surgeries, which Americans routinely get in days. In some parts of Canada, the waiting time for an MRI, for instance, a very routine test, the wait is over 1 year to get an MRI, a basic diagnostic image. The Canadian Supreme Court has admitted that people are dying on waiting lists in Canada right across the country. Over the years, my organization has sent well over 500 Canadians to the U.S., and we refer to the U.S. as Canada's healthcare system of last resort. If you are dying, if you cannot get care, there is always the option to go to the U.S. 2 years ago, building on our success and our experience, I founded North American Surgery. This company negotiates deeply discounted pricing for surgical procedures for uninsured Americans. In the course of this work, we have saved the lives of 6 of our fellow Canadians. We never had the opportunity to work with Shona.